Good morning, and welcome to this week's episode of the Ask Dr. Murphy series. My name is Katie Berg. I'm a research coordinator here with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Morning.
Our viewers will remember Dr. Murphy as the Executive Director of the Havey Institute for Global Health, as well as the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, or public health questions each week here on our Havey Institute Facebook page. Today, Dr. Murphy will be answering a viewer-submitted question as well as addressing the latest headlines related to the public health sector. Today is August 31st, and we invite you to submit any questions per usual at any of the places down below. You'll see our email, our Twitter, our Facebook, and as well as the YouTube comments we always respond to. Starting with some updated United States COVID statistics. As of May, the case number per day is around 10,305. No updates there. Average new hospitalizations per day, which we do have concrete data for, is 1,152 per day. Average deaths per day from COVID has risen to 46, and the new booster proportion has stayed steady at 17%. Dr. Murphy, your reaction to those numbers?
Yeah, going in the wrong direction. This is our little end of summer bump in cases. And for the last at least 2 months, the cases have been increasing every week. And that just is continuing on. We don't know how many cases there are per day because they're not reported anymore. But we do know the hospitalization rate, as you mentioned, up at least 18%. And the number of deaths is up over 20%. Now, the numbers are still low, those numbers, compared to what was going on before. But this is going in the wrong direction, and this is yet another end of summer wave. So we've had this before. We had it with Delta 2 years ago. It happened last year, and it's happening now. They're finding it all over the place, and there are definitely more and more cases, and they're even finding super spreader events. And in the one case in the city of Nashville, at a city council meeting, more than 12 people got infected, including the council members, city employees, and at least one reporter in a super spreader event there. That is just, it's happening everywhere. In Chicago, they're averaging about 11,000 hospitalizations per day. That's up from 7.8. So, the numbers are small, but they're increasing in a big way. Also in Chicago, the wastewater monitoring shows an increased concentration of COVID-19. So that's just another marker that we have. And the Chicago public school system is offering free COVID testing to students and staff, although it is not re-implementing testing in every school, but at least they're gearing up. I was at a wedding last weekend, and the poor bride got COVID the night before the wedding. So they were thinking of canceling it or whatever, but they informed everybody. Everybody that came had been vaccinated, and we went and bought some tests. And I was really surprised to find that when I went to the pharmacy to use my own insurance card to buy a few tests, that the insurance no longer paid for it. I even called the insurance company. This is Blue Cross Blue Shield of Illinois. It's a very good policy, usually. And they just said, oh, the pandemic is over, Dr. Murphy. And you have to buy them yourself. So I spent almost $200 buying these tests. And I imagine, the typical person, some people are going to have a hard time going to buy $200 worth of tests or $100 or whatever. It's like 20 some dollars per box that has 2 tests in it. This is not going to help. And the response, I said, why are you doing this? They said, well, you can go to the emergency room or urgent care. Oh, yeah, sure. you want to pay all that money to take one of those approach rather than buying a $20 box of test kits. I thought it was, it was really stupid, and this is what's going to happen. And now the cases are going up. People are not going to get tested. So therefore, the wave is going to be even bigger. It's just really, from a public health standpoint, is ridiculous. So the pandemic's not gone. COVID's still here. We're still talking about it. And we'll see how big this wave really is.
Absolutely. And that's very interesting. We've been keeping a close eye on whether or not the new vaccines would be able to be given out for free, supplied by the federal government. But the testing has kind of fallen through there. So that's something really important to keep our eye on, and a great point. That brings us to our viewer submitted question for the week. I'd like to give a shout out to Elaine, a longtime viewer who submitted several questions and a great one this week. She asks, Dr. Murphy, does a previous RSV infection, perhaps at the end of last year, afford a person any immunity to RSV if they are not in the group eligible to receive those vaccines, so under 2 or over 60?
Yeah, so RSV, no one ever talked about this before, but it turns out it's easy to test for. And there's a vaccine for it now that's approved for people 60 and over, or if you have some underlying disease. It's also approved in pregnant women because the women make the antibody, and babies are another group at high risk for having serious disease. So you vaccinate the pregnant woman, and then the baby gets the protection from that. And little children can also get these monoclonal antibodies. So there's things you can do about RSV. RSV kills about 10,000 people per year. So it's a serious, can be a serious disease. Now, the problem with RSV is that if you do get an RSV infection, you do get some immunity, and the chance that you're going to get it again in the months following that one infection are pretty low. But it's like COVID in a lot of ways. That immunity wanes. You get some protection, but not all the protection, and so forth. So think of it in terms of like COVID, and that you're likely to get it again. It's probably going to be a little bit milder, and there is something you can do about it. And you can take this new RSV vaccine if you're in the eligible group. It is particularly severe in people, like I said, who are older, but also in transplant patients and in very young kids under a year old. That's the really high risk group. So it's another way you can protect yourself if you want. If you believe in these studies, thousands of people studied with the RSV vaccine, and it is approved by the FDA.
Mm-hmm. Absolutely. And that's a great point to mention, that it's not only eligible for people 60 plus, pregnant women, people under 2, but those who do have those underlying conditions. So make sure that, if you do have an underlying condition, you look into whether or not you are eligible. Could be a big help.
To be clear, the children don't take the vaccine.
The children receive the adjuvant
monoclonal antibody. It's the mother who gets the vaccine. So it was an interesting approval.
Right. Pardon my confusion of the adjuvant versus the maternal vaccine. But that does segue us very well into a big headline this week, which was that the updated COVID-19 boosters may be earlier, or maybe ready earlier than we expected. Could you give us that news?
Yeah, so a couple months ago, when the FDA approved, the advisory committees approved, and the FDA went along with it, and the CDC advisory panel, they also went along with it. Say, oh, well, we'll roll them out with the flu vaccine. So the end of September. Well, here we are, it's August. We're having a wave of COVID, just like we did other years. So people are thinking maybe you should give the booster for the COVID in July, before this wave comes again, because this seems to be happening all the time. It's not, flu has just this one wave that comes every fall, and it goes away after 6 months. So it's very important because the pattern is very different. The new vaccine is strictly based on Omicron, the Omicron variants, which are the circulating viruses now. The old vaccine probably doesn't do much against Omicron, to be honest about it. So, we got to get this new one out there. It's ready to go. Because of this bump up in cases and because of these new variants, the BA 2.86, which looks like it's mutated significantly from the original Omicron. There's now 24 people in 8 different countries. So Sweden and Canada just got added to the list. And so that's starting also to take off. The UK has approved the release of the new vaccine for September 11th. So a week from Monday, they're going to start rolling out the new vaccine. So, a couple weeks earlier than expected. And the United States, we just read just this past week, it said that they're going to roll it out mid-September. There's another advisory meeting, I think, on the 12th. They'll probably approve that most likely, and they'll move the new vaccine up into the middle of September instead of the end of September. So people say, well, 1 week, 2 weeks, does it make any difference? It makes a huge difference because the rate of infection is so high. It's so fast. And you wait 2 weeks, you're talking about a lot of replication and a lot more virus floating around out there. So the question is, what do you do, like, if something is going on, like right now, you're making a decision about the vaccine. Dr. Mandy Cohen, who's the new CDC director, I think she stated it quite well. I'm just going to read this. Unless a person has never been vaccinated and never been infected, so they've never been exposed at all, it's probably better to wait until the new vaccine comes out in September rather than opting to get one of the older bivalent vaccines now. So wait, basically, she's saying. And I think everyone pretty much agrees with this. We've been saying this, I think, every week for the last month or so. Wait to the new vaccine. The new vaccine is going to be much, much, much better. Now, if you've never had the bivalent vaccine and for some, you're going to travel somewhere exotic or something like that where the medical care may not be as good, you got to make a personal decision to take that vaccine and then come back, wait a couple months, and then take the new vaccine. There's going to be some extenuating circumstances that you have to take on a one-on-one basis to see whether you should take it or not. But this is, you definitely want to get this new one because it's really geared for what's going on right now. And hopefully, even with this new BA 2.86 variant floating around, that is even more contagious than the old one.
Absolutely. And your point about not waiting makes a lot of sense also in context with the fact that once you get the vaccine, it's not 100% effective. It takes time for that immune response in your body to build up. So the earlier you get
it takes a couple weeks to get the immunity, to get it built up on top of what you have already. But it is important to get it's just as important, like with the flu. Like, we wouldn't give last year's flu vaccine this year. It wouldn't work. That's what's happening with COVID. So these vaccines are going to have to be modified every year, or in the case of COVID, could even be more frequently. We'll see.
Yes, excellent point, and something very interesting to keep an eye on. Our next story today is a very interesting long COVID study that was published by one of your colleagues here at Northwestern. Just a little blurb in the Trib this week. What can you tell us about it?
Yeah, Dr. Igor Korelnik is a neurologist here at Northwestern, and he founded and runs this big long COVID clinic here and has published pretty extensively on it. And he has found in their studies there's a very large population in the US and the world who are the negative long haulers. In other words, these patients have long COVID without ever knowing that they had COVID in the first place. A lot of people had asymptomatic infection, or they had, such a mild infection they didn't know what it was. And he thinks that there's about 10 million people who don't have an official COVID diagnosis, but are having the same kind of symptoms that the known long COVID patients have. And this includes in children too. So, it's this long COVID is a little bit mysterious. It's more common than we thought, and it can happen even if you don't even remember having COVID in the past. And is the way that the testing is going now, this is going to happen more and more and more, because if you can't afford to go out and buy tests for your family, say you have 2 kids and the adults and maybe somebody else around the house, you got to go buy 3 to 6 boxes of those things. That adds up. And a lot of people, that'll be very stressful. Hopefully they're going to loosen up this testing, because it really is critical to find out that people find out what they are, if they're really positive or not. And what will happen also in the next few months or so is the new test will come out, and the new test for flu, and some of them even for respiratory syncytial virus, RSV, at the same time. So then you really know what is going on with you.
Absolutely. And hopefully we're taking a bit of a turn. We've been talking a lot about mosquito-borne illnesses the past few weeks in these heat waves and rainy seasons. This week, we finally have some better news to look forward to or report to you. So Dr. Murphy, what can you share with us about the malaria news that came out this week?
Well, malaria remains a life-threatening disease worldwide. I mean, it kills, especially children and pregnant women are really susceptible to it. And what they found in a study done in West Africa, in 2 countries where we have worked for quite a while, Mali and Burkina Faso, they published this, or the study was actually done in 2017, and they found that there is a vaccine. It doesn't work for a very long period of time, but malaria comes in seasons also. It's associated with mosquitoes, so it's the wet season. So in the wet season, giving that vaccine and giving pills that can prevent malaria from happening decreased the deaths, the anemia, the transfusions, all the other things associated with malaria by 2/3. I mean, it was really dramatic, the impact. And if you throw in treated bed nets, sleep under a bed net that has like a medicine in the net, it's a 90% reduction. So this is pretty dramatic. It's a little bit complicated, but it works. And because all these interventions, I mean, this is what we've got to do to lower this death rate, especially in kids. And interesting, we've talked about it a couple of times already, that malaria is actually popping up in the United States in people who haven't traveled. Now, normally it's people who've been to some place where there's malaria, they come back and they get sick. But there have been now cases of people just getting malaria. There was one recently reported in the state of Maryland. Just somebody's got malaria, and that's very interesting, and we've got to be careful. And that because people that have never had malaria before get really, really sick the first time, and young kids in particular, and pregnant women, are so much at risk, and they can die from malaria. So that's why it's important.
Mm-hmm. Well, thank you so much, Dr. Murphy, for informing us on these headlines and answering our viewer-submitted question. We, as always, appreciate your time and expertise. So thank you so much.
Well, thank you, and have a good Labor Day weekend and end of the summer. Try not to get COVID.
Absolutely. Thank you to all of our viewers as well. As always, we invite you to submit any questions you have down in the description below via Facebook at NU Institute for Global Health, or our email globalhealthinstitute@northwestern.edu. Thank you very much, everyone.